everyone, welcome to CardioVisual. My name is Matt Holden, and today we're going to talk about atrial fibrillation, or AFib. Before we dive into AFib, let's quickly review the normal electrical activity of the heart. Under normal circumstances, the heart's rhythm is controlled by our sinoatrial node, or SA node for short, which generates a regular impulse that spreads throughout our atria, leading to a symmetrical atrial contraction. It then travels to our AV node, which then allows it to pass to our ventricles. And now you're going to see a P, QRS, and a T wave. The P wave represents atrial contraction, the QRS complex shows ventricular contraction, and the T wave represents ventricular repolarization, and we call this a sinus rhythm. Now let's talk about what happens in atrial fibrillation. In AFib, the SA node no longer drives the heart's rhythm. Instead, we have multiple ectopic foci within the atria that start firing off erratically. This causes the atria to quiver instead of contracting properly. What does this cause? A loss of effective atrial contraction and an irregular heart rhythm. Now let's break down the word atrial fibrillation. Atrial means top part of the heart, and fibrillation essentially means quivering. So the top part of the heart is quivering around about 300 to 600 times per minute, but our ventricular rate is not that high due to our AV node acting as a gatekeeper and blocking some of these signals. So why does AFib happen? Basically, over time, the atrial remodel, which can lead to changes in the atrial tissue itself, causing tissue heterogeneity. This remodeling alters our action potentials and repolarization periods, creating just a chaotic environment inside of our atria. These changes are often caused by long-term pressure or damage to our tissue. One of the issues that we see with atrial fibrillation is that due to the loss of organized atrial contraction, this actually reduces the heart's efficiency, making it harder to pump more effectively and increasing the risk of clots, but we'll get into that a little bit later. Now, let's discuss some of the common causes of AFib. We can divide these into our cardiac and non-cardiac causes. Some of our cardiac causes include your valvular heart disease, especially your mitral stenosis, because this increases our left atrial pressure due to the blood having difficulty being pushed into our left ventricle. Another one is going to be pulmonary hypertension, where there's basically an increased pressure on the lung side, which puts strain on our right ventricle, thus our right atrium. Long-standing hypertension and ischemic heart disease are other ones. On the non-cardiac side, we have holiday heart syndrome. This is when people develop AFib after binge drinking alcohol. Electrolyte imbalances such as low potassium or low magnesium, and thyrotoxicosis, which is basically overactive thyroid, speeds up your heart rate and irritates it. Other causes like obesity, diabetes, and even high stimulant use can increase your risk as well. Essentially, if you want to think of what can cause AFib, it's a whole slew of things. Inflammation, stress, or anything that causes any kind of increased pressure or atrial stretching can cause AFib. Now we get to talk a little bit about our complications of AFib. So as we know, AFib isn't just this fast or irregular rate. It does have some complications. One of these is that you lose something called your atrial kick. Normally when the atria contract, it's able to efficiently push our blood into our ventricles, providing approximately 30% of the heart's output in some patients. In AFib, the quivering atria no longer provide this quote-unquote kick, reducing the overall efficiency of the heart. Another major concern is obviously going to be our blood clots. Since the atria are not contracting properly, blood can pool in the atria, especially in something called our left atrial appendage. This stagnant blood inside the left atrial appendage can form clots and can travel to the brain where it can cause a stroke. So now we're going to talk about our various classifications of atrial fibrillation. AFib can be classified in a few different ways. First off is paroxysmal, which lasts less than 7 days and usually resolve on their own or are self-terminating. Persistent AFib lasts more than 7 days and often requires some kind of intervention. Long-standing persistent means it's lasting over 12 months. And permanent is greater than 12 months, but there's a joint decision between the patient and provider to not continue to convert the rhythm into a sinus rhythm. So let's talk a little bit about our EKG findings inside of atrial fibrillation. On an EKG, atrial fibrillation has a few kind of hallmark features. First off, you're going to possibly see something called fibrillatory waves. Instead of your clear-cut P waves, which you see in a normal sinus rhythm, you'll see a wavy baseline due to erratic electrical activity up inside of our atria. Next, you notice that the rhythm is going to be irregular, which means our R-to-R intervals are highly variable. Another thing I would like to talk about is something called rapid ventricular response, or RVR. You've probably heard this before. This occurs when the AV node allows way too many impulses to head through, leading to a fast ventricular rate. In medicine, we like to overcomplicate things and say big words, but basically RVR is just AFib with over 100 beats per minute. So let's quickly look at this. If I look in V1, you can kind of see this fibrillatory waves up here. There's no clear-cut P waves anywhere. And if we were able to zoom in on the bottom strip for irregular rhythms, we can see here that our R to R is completely variable. Now, we get to talk about a management of our atrial fibrillation. So how do we manage it? There's two main strategies with this. Number one is rate control, and number two is rhythm control. With rate control, we're focusing on controlling the heart rate, typically aiming less than 100 beats per minute, and this is usually achieved with some kind of beta blocker, calcium channel blocker, metoprolol, or diltiazem. Digoxin is also used, and when all else fails, you can send the patient to the EP lab and they can have an AV ablation and they can have ventricular pacing in there. AV ablation with a ventricular pacemaker is usually the last line after pharmacological efforts have been exhausted. Now, rhythm control aims to restore and maintain a normal sinus rhythm, and this can be done with a ton of different medications. Some of the ones I want to really talk about is like your amiodarone and your flecainide and sotalol. Those are the ones I see more. It's important to remember that when you are using flecainide, you should also give a beta blocker or calcium channel blocker to avoid a dangerous rhythm called one-to-one atrial flutter. Flecainide should also only be used in patients without structural heart disease. And another one that is also used, electrical cardioversion. Essentially what you do is you make sure the patient does not have a clot. You can do a transesophageal echo or TEE, and you can make sure the patient does not have a clot inside the left atrial appendage. And you can sedate them, and then you can place pads on them and then electrically cardiovert them. As we know, patients with AFib have a significant risk of stroke, so anticoagulation therapy is often used. We use something called a CHA2DS2-VASc score to assess stroke risk and to determine whether a patient needs to be on a blood thinner like warfarin or a direct oral anticoagulant or DOAC. DOACs are preferred as they're easier to manage. Warfarin is required, though, in patients with mechanical heart valves or severe rheumatic mitral stenosis. Warfarin is a vitamin K antagonist and is an anticoagulant which blocks the synthesis of clotting factors 2, 7, 9, 10, protein C, and S. The way I kind of remember the clotting factors it affects is 2 plus 7 equals 9, not 10. Eliquis is a direct oral anticoagulant, or DOAC. It inhibits factor 10A. In some cases, catheter ablation can be used to destroy the areas of the heart that are causing these erratic signals. For patients with refractory AFib, another option can be the maze procedure. Now, I would like to thank everyone for watching. If you have any questions or want to learn more about the specific treatments, leave a comment below. Don't forget to like and subscribe and hit the notification bell so you don't miss out on any future videos. Until then, have a great day.